Good afternoon, friends. I am Arup Chakrabarti, the lead instructor for this course, which has been going on for a couple of years in All India Ophthalmic Society meetings. So it is now a cliche to say that cataract surgery is refractive surgery. You need to hit the bullseye each and every time, and that usually means hitting 6 without any residual refractive error. So that is the holy grail, or whatever be the target refraction, hit it without a residual refract, without whatever the correction you're aimed for. So where are we? We need to know what is exactly is our target. So I would quote from the literature and evidence a very informative article by Savini et al. Published in JCRS, where all the measurements were performed using a swept source OCT optical biometer. Large number of formulas were taken into account. There, the formulas were ranked based on a prediction error of plus minus 0.5 diopter, and it was noticed that all these modern formulas were able to take us to 88% to 90.67% with a prediction error of 0.5 diopter. So if we are not there, and we need to find out where we are, so we have some distance to travel. Beyond that, whether further improvement happens or not, there are a lot of factors that are beyond our control. I'm not going to discuss those issues in my presentation. So basically, we need to be, using cutting-edge instruments and devices, use the current formulas, proper lens constant optimization. So in this presentation, all these aspects will be covered, and we have Dr. Anurag Mishra talking to us on contemporary tools, strategies to optimize toric outcomes. Dr. Ramesh Durarajan, incorporating cutting-edge technology in IOL calculation. Kumar Doctor is in the IPL, so he'll come as soon as his commitment is over. Dr. Meena is doing a course, he'll be here. IOL power updates in common posterior segment post pathologies. We have been doing a lot of combined cases for the last 30 years. So she'll be sharing her experiences. So even recent developments in post-refractive surgery situations. And I would like to invite, I'd like to invite Dr. Nirupama Kasturi. She is an associate professor and head of the Department of Ophthalmology Department in JIPMER, her first course. So welcome, Nirupama, and hope you go from strength to growing strength, go from strength to strength and become a very active person in AIOS. So what I have realized over the last so many years of refractive cataract surgery practice is IOL calculation is not a single incident in the patient's cataract history, surgical history. It transcends or it pervades the preoperative period, the intraoperative period, as well as the postoperative period. So most of the things happen in the preoperative period, but then we have a lot of things to learn, a lot of information to glean from the intraoperative happenings and the postoperative outcome. So this is an overall process. This is not a one-off test that we do. Patient examination and evaluation is very important because you need to know the sources of vision loss and what are the factors that are present in the patient that could influence the accuracy of IOL calculations. And only then the IOL calculations as such will start. So we have known over the last couple of years that ocular surface is extremely important. And if it is unstable, you got to stabilize the ocular surface. And we know that in unstable ocular surface, if you perform the biometry, you'll be having residual refraction. You will not be meeting the target refraction in your monofocal IOLs, multifocal IOLs, or even in toric, or also in toric IOLs. So you need to optimize the ocular surface, repeat the biometry every few weeks till you get two test investigations which are the same, which are reproducible, consecutively repeatable. And whenever you perform biometry, it has to be done on the virgin cornea before you perform any diagnostic evaluation on the eye. So no prior cataract procedure has to be done. Sometimes it may become a little impractical to do it, but we always talk to the patients that in your interest, we need to come back for your workup several times. Sometimes we dilate the pupil to get a better biometry reading. And say, for example, so does it affect the quality of our measurements? So actually there was a paper recently published in November 2022 which showed that even if you're using a swept source OCT biometer, if you're not happy with the scan quality, if you dilate those eyes and repeat the examination, you'll get a better scan quality and different and better values which are more reliable. So it definitely makes a lot of sense to dilate these eyes in those situations where you're not very satisfied with the scan quality. But then there is another thing that we have known for quite some time, that once you dilate a patient's eye, there's alteration of the various parameters, and the multivariable formulas like what I mentioned here, which use multiple variables, definitely may land in erroneous values in the postoperative period. Let me quote from this particular paper. It shows that after dilatation, the central corneal thickness, anterior chamber depth, lens thickness, everything increases. That is statistically significant. So if you use the biometric values after the patient has been dilated, and you are likely to have 25% of a patient have an IOL power which is 1.5 to 1 diopter more than what it should have been. So whenever I dilate a patient to get a better biometry, I always tell the patient that I am not sure about your target refraction. Usually I'm quite pretty sure, but in your case, I tell them the statistics, and also tell them that there's no way I can tell whether you belong to this 25%. So a good counseling definitely helps. Sometimes we put tear film stabilizing drops on the patient's eye. So if you do that, then you need to wait for a minimum period of 5 minutes for you to get more accurate results. And after all that, you can optimize your outcome by having a proper understanding of instruments and devices, and then we have talks on that. Use current formulas, and a constant optimization is very important. So today I get all my values from the IOL Master. If you're using keratometer or manual keratometer, auto refractometer, it is okay, no problem. I also use a topography and eye trace. If a patient is on contact lens, then prior to keratometry, it has to be off the eye for at least 2 weeks in hard contact lens situations for it to get better values. In our scenario, we definitely cannot abolish the use of ultrasound biometry. So if you have one, please perform only immersion scan, because the contact scan, the apprehension scan is less accurate, and it results in mean average shortening of axial length to the tune of 0.25 to 0.33 millimeters. And this was a meta-analysis done by Professor Hygie's, which has clearly shown the pink bars that even if you compare immersion biometry with OCT-based biometry, in that with optical biometry, you get better results with optical biometry. So there are so many devices in the market. Now, if you are using the older generation machines, which machine do we go for? Now, there have been a lot of studies in the literature, and I have just picked up one study which compared Aladdin and the Lenstar, and it showed that there is a good level of agreement. So there is nothing for us, nothing very important or useful for us to select one machine over the other than the service and price and other issues of that particular machine. Now, those of us who are planning to upgrade to a swept source OCT-based biometer, it costs a lot of money. So do we really need to upgrade? So of course, the IOL Master 700 has additional features, and you can see the fovea. It gives a lot of other additional factors in addition to performing the biometry. But then it shows that the results are pretty accurate to IOL Master 500, though its penetration is much less, comparatively less compared to IOL Master 700. So you can take your call based on that. Now, if you just use an optical biometer for a patient, you cannot rest assured that whatever value you're getting is absolutely pure. There are validation guidelines for various machines which are put up in their website, and we have put it up in our OT, where the procedure workup is done, for patient workup is done. And as soon as the optometrist or whoever is the biometrist finds out an abnormal value, when there's a red flag, that value is deleted and we redo it. So basically, it is the doctor who is in control, and he has to guide the optometrist or the biometrist from time to time as to how to pick up a good quality biometric value. Now, hard cataracts, as I mentioned earlier, that it may be a problem with IOL Master 500 and the older generation OCT machines. So now I use IOL Master 500. So supposing this particular cataract will not give any result with IOL Master 500. If the fellow eye is clear or is a pseudophakic eye, so I will do both IOL Master 500 for them as well. I get the axial length from IOL Master as well as immersion scan. And most of the time, if the nurses are good, if the values correlate, then you can rest assured that the technician is doing a good job. I repeat it once more, and then most of the time, more than 90% of the time, there's a good agreement. So we can still go ahead, and perform an immersion A scan for those patients. Last 20 years, 25 years, we had about 5 formulas that are available to us. But recently we have a number of formulas that have come, almost 25 formulas that have come. So the new thing in the market is the Hover QST, which is uploaded which is free in the ESRS website. But I still use the Barrett Universal 2 formula because of various reasons. It's a complete suite. It lets you calculate IOL power for all kinds of situations, as you mentioned here. And it is free. It is available in the website. And it's very accurate, and you don't have to modify the axial length even if it is a highly myopic eye that you're dealing with. And it can also be used when you have got values using your immersion A scan. Just that you have to change your appropriate A constant. You have to change the A constant for this patient. Heal RBA formula version 3 has become quite versatile, and it also gives very good results. So, I normally use Barrett Universal 2, and extremes of cases, I reconfirm the values with the other formulas like Kane formula, then Hill RBA formula. Kane formula is a very good formula. It calculates both non-toric, toric, and it has a separate keratoconus specific software. It is gender specific, and it has done extremely well in the recent past for different types like toric IOLs, for post-vitrectomy cataracts, for keratoconus eyes. And as I mentioned earlier, when I'm dealing with extremes of the eyes, I calculate the power using multiple formulas. Here, Bangkok optimization was done for SRKT, Holiday 1, Hygie's, Hoffer Q. Suggested AMO sensor of 3 diopters. Barrett Universal to give me 2 diopter, but I used the 3 diopter intraocular lens with very good results. Intraoperatively, make sure that your lens is in the bag. The temporal 2.4 millimeter clear corner incision, central rexis, lens in the back with good uniform overlap. That is actually has become the standard pattern. Almost all of us are doing that surgery to that kind of refinement. Post-operative period is the moment of truth, because there you get to know what is your refractive outcome, how you need to fine-tune your refractive outcome. Lens constants, most of the time, we use the lens constants for all these branded lenses, which have been used in large numbers in the softwares that we are using in Heal RBA or Barrett Universal 2 or Ken formula. But if it is a new lens, in Indian lens, and you are not very sure, then you use the manufacturer's A constant with a little bit of trepidation, and then that have to be optimized depending upon your experience. Now, sometimes when a patient agrees for surgery in both eyes at the same time, within a span of 1 or 2 months, so I always take the information from the results in the fellow eye. So, for example, the first eye I have operated, and of course, both the eyes should have intraocular symmetry. The first eye post-op error, prediction error should be more than 0.5 diopter, and there should not be transcription error. IOL malpositions should be excluded. Now, what I would do is, I would not take into account the full, say for example, I have, let's say, minus 0.9 the refraction is minus 0.9 diopter. So I'll not set the target refraction at 0 or plus 0.9 diopter. I'll set the target refraction as plus 0.3 diopter. That is 30% of the prediction error of the first eye for Barrett Universal 2. And it is the 50% that you correct for the other formulas. And even the Pearl DGS calculators come up with the second eye enhancer. We have got to realize that many of these formulas are gender specific. For example, the Barrett Universal 2 is more precise for males than females. Remaining formulas are more accurate for the females. And so these gender differences are more pronounced in the extremes of axial length or anterior chamber depth. So friends, never do the preoperative measurements on the naive cornea. Use validated measurements. Work with properly optimized lens constants. Adapt to new technologies as they present, while remembering at the same time that anything new need not be the best, and it may go out of favor in times to come, to be replaced by something else which is better. Employ the right formula and strive to use all available resources to their best advantage. Thank you so much for your kind attention.
Thank you, Arup sir, for this wonderful opening statement to the instruction course. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. There are many contemporary tools in the market right now operating with us, but my job is to take you through some of those contemporary tools which are essential for the toric IOL calculation. So I'll just run through three of the equipments that are important as far as the toric IOL planning and implantation is concerned. Image guidance and biometry, we have both of them combined together now. Topography, anterior segment OCT, and biometry, again, all three combined into one equipment. And then finally, we'll just look at the aberrometry results and what do they teach us with regards to toric IOL planning. So the machine that combines image guided and biometry is called the Argos. And this is the way it works. It takes the measurement in less than a second. And these are all the measurements that it gives us in a flash, all the measurements that it gives us in a flash. This is how this screen looks like. It's still just like Varian, it's older gen equipment. It uses a single light of 16 LEDs at 2.8 millimeters, the central cornea, but it gives us a very dynamic keratometry values. This is something that is important in this machine. This central green should be aligned with a cross. That's when you should click the joystick to start taking the measurement. That's one. And second is this green line out here. As you can see, it lies parallel to the corneal vertex. If it does not lie parallel to the corneal vertex, then you know that the eye has not been properly aligned to the machine. Then you have to retake the whole reading. It has two USPs, this machine has two USPs. One is it takes into account the differential refractive indices of the tissues through which the light ray has to pass. The earlier equipments, what they used to do was they used to take 1.3375 as one refractive index, common refractive index for all the tissues in the eye. This takes differential refractive indices. So the axial length changes, however minimal it may be, but it does become clinically significant in some of the issues. The other thing is extended retinal view, or ERV. Let's understand what that is. First, this is the refractive indices of the different tissues that the light passes through, and the machine takes into account all of that. And second is this ERV. So what it does is in the dense cataracts, in the normal mode, it calculates the length from the corneal vortex to the posterior capsule. And then you switch on the ERV mode, which takes the distance from the posterior capsule to the cornea. It just enhances the view modifies the view that is taken from the posterior capsule to the cornea. Then it stitches them together to give us the complete axial length. And we can analyze it to see whether they are aligning properly in one line or not. If they're not aligned properly, we can retake the reading. But what has given me at least is the liberty to subject the most densest and the whitest of cataracts even to the proper axiometric values. It's really, really perfect, this machine, when it comes to axiometry in those circumstances. The other thing it does is it plans the cases for you. As for example, in this case, as you can see, it predicts a T3 and a T2 in the same patient to bring about the same result, but the incision size is different. With a T3, you can achieve the same result with a 2.2 millimeter incision as you can achieve with a T2 producing a 2.8 millimeter corneal incision. So it essentially flattens the axis a little more. So if you do not have access to that particular variant of toric in your inventory, you can modify that with the help of this machine. This is another patient who had planned, whom we had planned for a trifocal implant, but if the patient was being left with a 0.58 cylinder post-operatively, the machine told us that. We asked the machine to do an arcuate planning since this patient was also opting for femto, and the machine did that. So it told us that there is an arcuate incision, paired arcuate incision to be done at 152 and 332. The arc length should be 22 degrees, the depth should be 85%, and the diameter should be at 9 millimeters of cornea. Then the residual refraction would be 0 or negligible, is what the machine told us. So these are the advantages of the image-guided system. This is another patient wherein there was an expand series IOL required of +3 diopters, but since the patient was also opting for a femto platform, we managed to neutralize. After T9 implant, also the patient was left with some amount of cylinder, which we could adjust with a paired arcuate incision on the femto platform. So this is what the Argos does in a nutshell. Of course, this can be expanded to a lot more. Anterion is a machine that comes from Heidelberg, and it combines AIOCT with front and axiometry, along with a few other things like the topography as well. This is how the picture looks, and this is how the printout comes. You can also have a reliability index looking at the A-scan picture that it gives you, a complete A-scan picture that it gives you. It does give you the chord mu length as well, which we commonly call as angle kappa. And this is a topography, the anterior and the posterior elevations. However, unfortunately, it only expands the 8 millimeter zone of the cornea. It doesn't go beyond that, so you don't know what's happening in the very peripheral parts. This is the acquisition quality. The machine gives you a printout of, a window of acquisition quality. So it does give you a fair bit of idea regarding the ocular surface, the tear film and lid, whether they pass or not. So the machine senses that there's something wrong with the ocular surface. You can go back and treat the patient for a few days with lubricants and then call him back for another set of biometry just to achieve perfection. It gives you an idea regarding the lens tilt, so that's also important in toric. Some of the patients wear glasses, but actually the corneal indices do not show that they have toricity on the cornea. That might be a lenticular astigmatism. When you subject them to the ASOCT, you can see that the axis of the eye does not match with the axis of the lens. It's slightly tilted, so that's another information that you can get. It does give you the access to calculate the toric IOL power based on predicted posterior corneal astigmatism and measured posterior corneal astigmatism, since this is a tomographer. So this is one example where the predicted corneal astigmatism with the predicted posterior corneal astigmatism, the IOL power, the T3, the toric version came out to be T3, but when we switched and we went to the measured posterior corneal astigmatism, it gave us a T4 reading, as you can see down below. However, if there is a disagreement between the predicted and the measured posterior corneal astigmatism values, I still go with the predicted value because the Barrett's algorithm is too good predicting the PCA for every individual case, as we have found out over the time. This is the wavefront of the aberrometry that I use, the eye trace. Now, this patient, for example, wanted a trifocal. As you can see, the angle alpha is doing fine. We can go ahead and plan a trifocal. The delta or the toricity index in the cornea is 0.95, so fine. We can go ahead and put in a trifocal toric. But what's interesting is on the corneal front, if you look at the total spherical aberration, that is somewhere around 0.009. So you have to be very careful in choosing the IOL which has more negative asphericity, because the total resultant asphericity of the eye should be slightly on the positive side or should be at zero. It should not go on to the negative side. So what happens when the total spherical aberration goes on to the negative side is, this is one patient wherein you can see the spherical aberration of the total eye is minus 0.001 mu. This is a post-operative reading of a patient. The patient came to me very dissatisfied with the quality of vision he had, and when I subjected him to the eye trace and then the dysfunctional lens index, look at the distortion the patient is having from the internal plane. Nothing wrong, everything superb, very well done surgery, but still the patient is not having a very crisp vision because the total resultant negative spherical aberration was on the negative side. And finally, before I sign off, this is also something that we must look at, the ocular surface. If we have access to the ocular surface analyzer, dry eye suite, then wonderful. If not, then we can do certain simple tests to rule out whether the ocular surface is doing well or not. This is one such patient who also had qualified otherwise for a trifocal implant. But when we saw the patient preoperatively, the lipid layer was doing very bad in both eyes, standing at 57 and 55. So sent the patient back with antibiotics and ointments and warm compress for a period of 3 weeks. And the patient came back, the lipid layer improves to 87. Now you're much likely to get a proper biometry reading, which will help you identify the exact toric placement, because this is what happens when the dry eye comes in. If you look at the right eye picture of this particular patient, this one of the Myers is not properly taken and it's marked cross. The delta in that reading shows to be around 0.27. The delta in the other two readings where the Myers were proper shows to be 1.56 and 1.30. So the total delta comes down a lot, which is 1.09 as the reading shows here. This patient does not require 1.09 of toricity to be corrected. He requires more toricity to be corrected. It was modified because the eye was dry when this first reading was taken. So if you come across these sort of readings, it's important for us to actually go and analyze the readings that come from the biometry rather than blindly believing them and finding out whether the surface is doing well and the biometry has been taken in the proper settings. So these were just a few nuggets on the toric calculation with regards to the contemporary tools that we have in the industry. Thank you so much for the opportunity and the kind attention.
Thank you, Dr. Anurag. Next, we call Dr. Ramesh Durerajan to deliver his talk on the newer technologies available for IOL power calculation.
Thank you so much. Can you all hear me? You may have the echoes if I turn on both. Okay, there we go. So we all would like to use extremely high-tech equipment in our practice, but it should be appropriate. And what is high-tech and affordable will differ if whether I have a small practice in a rural setting, a small group practice, or a very large practice in a urban setting. So our technology should be appropriate. Some of the high-tech technology is free and available online and can be used for patients when needed. And the previous speakers spoke about Kane Evo and the Hill RBF formula. So in any unusual eye, please use these formulae. There are many components where high-tech can be used, but in general, this is the nomogram suggested by Douglas Koch to get 90% of your patients within 0.5 diopter. He says, initially do a tomography to rule out structural anomaly in the cornea. Then, like Dr. Arup said, please measure 2 weeks apart and see whether the measurements line up. If possible, measure with more than one instrument. Measurement of the corneal power is very important, and optimizing the tear film will help you to achieve better refractive goals. So you can do this by low-cost measures. Like for example, you can apply warm, moist compresses with a hand towel, or use these microwavable heat masks which you can buy from Amazon for about 1,500 or so, or you can use other techniques. You can also clean the eye with a dilute Johnson baby soap, or you can buy commercially available lid scrubs or hyposilin sprays. Then you can use preservative-free drops 4 times a day for 2 weeks. This is the standard used to generally optimize the tear surface. You have more expensive options like using a microsponge to remove the biofilm and the exfoliated cells that you can see on the photograph above. You can use an IPL, thermal pulsation, thermal expression, or go for a less expensive method like a Maskin's lid extractor. There are a lot of variable technology in axial length measurement, but in general, all optical biometers will give you excellent results. The SSOCT-based devices are slightly better, and some of them are better than the others in acquiring data from eyes with white and intumescent cataracts. There are a few papers showing that the IOL Master 700 tends to get more values in mature cataracts when compared to the Anterion. And when I compared those two, I found that TOMI can penetrate in some of those white cataracts and intumescent lenses where the IOL Master 700 fails. So in general, all these machines are very good, and they help you to review whether each of these values are accurate or not. So if you put garbage in, we'll get garbage out. So the data that we put in should be good, and this is how you can see when a K is taken, you'll see whether the tear film was good, whether the reflex was normal. It will also help you to reduce errors because it will pick up things like an ERM, a macular hole, or a diffuse edema due to diabetes. It will also help you to reduce errors because all these are posterior polar cataracts. But if you see the posterior capsule of these 3 patients, you see a nice clear posterior capsule that is not bulging out. So these will have a normal prognosis, and we don't have to discuss things like PCR and vitrectomy with these patients. As opposed to this particular patient, do you have a pointer here? So in this picture above, you can see a small bulge in the posterior capsule, and in the picture to the right, we can see 2 small tears in the posterior capsule. The person on the right had anti-VEGF injections in Trichy, and then he came to Chennai for his cataract because his daughter was staying there. So the more advanced equipment like this, these are pictures from the IOL Master 700, help you to pick up these unusual eyes and tell the patient that you will be better off with this particular instrument. So the OPD3 is also one instrument which is quite useful. So it will give you various values, including the corneal asphericity, and then you can decide what exactly is the type of lens you want to implant in the patient. It also gives you a pupil-based summary of the amount of cylinder the patient has and the axis in which it is there. And in an irregular axis, for example, in the same patient, there's a 2.38 cylinder when the pupils are dilated, and there's a 6 cylinder when the pupil is in the mesopic condition. So the actual axis that this patient will accept will differ depending on the pupil size, and this kind of information helps you to understand the patient better and discuss with him about what his needs are. So there's a cost-benefit ratio to putting in in purchasing this high-tech equipment because insurance payouts are kind of plateaued and they're not kept up with the ballooning costs. And there's a need, as a pressure on all of us to enter a volume game as the cost per procedure is suboptimal. Now, why are we doing all this? We are doing all this mostly because we want better patient outcomes, but this should not come at the cost of us getting BP, diabetes, ischemic heart disease, and obesity, isn't it? So we should think whether this kind of high tech is appropriate and not pursue it just because it's available. In future, lots more things will happen, and this is an example of a B Vision product in Spain where they're using adaptive optics to measure the patient preoperatively, then modify the wavefront and give back a vision simulation to the patient. So below you can see the patient wearing a HUD through which they can see the environment and see what benefit they will get with a bifocal or with a aspheric IOL, with a trifocal lens or with a normal monofocal lens. This simulation can be done binocularly. So in the end, you can actually tell the patient how monovision will look and how the multifocal will look and how plane of a distance will look. So all these are in the pipeline and will help us to decide better. So in summary, low-cost, high-tech online calculators should be used for all appropriate patients. This is one way to adopt high-tech methods, and high-tech, high-cost solutions only when it's appropriate. Thank you.
Thank you, Dr. Ramesh. Next, we call Dr. Meena to deliver her talk on biometry in vitreoretinal situations.
Thank you, Nirupama. I'll be speaking on optimizing IOL power calculations in patients who have compromised posterior segments, who have undergone posterior segment surgery, either a vitrectomy or a scleral buckle. Since the volume of vitreoretinal surgeries are going up, there are more number of patients who have excellent posterior segment status who develop cataract and require cataract surgeries. In these patients, the challenges that we face are in axial length determination, especially if the eye has silicone oil tamponade, and secondly, in choosing an appropriate power intraocular lens, especially if a decision regarding whether to retain the silicone oil tamponade has not been made. We do not know whether the oil has to be retained for a long period of time or we are going to remove it. The difficulties in axial length measurement is the most important cause for nearly 54% of the errors in IOL power calculation. If you are using the A-scan biometer, it could be an overestimation of the axial length in silicone oil filled eyes or an underestimation of the axial length in a patient with macular edema, be it diabetic macular edema, vein occlusion, or epiretinal membrane. If you are using an optical biometer, it could be an underestimation of the axial length in patients with a very bullous retinal detachment, since the optical biometer calculates the axial length from the back of the cornea to the retinal pigment epithelial layer. The situation is again confounded by the presence of emulsified silicone oil and in eyes which has an incomplete silicone oil fill. The ideal solution to all this is to do an optical biometry for your patients before he is posted for vitreous surgery, retain the record in your hospital and give a copy to the patient also should he be going elsewhere for his cataract procedure. You can use either the optical biometer or the A-scan biometer to calculate the axial length. In whatever machine you use, the situation is challenging since the post-vitrectomy cataract is usually an advanced cataract with a thick posterior subcapsular opacification. And when you use an IOL master, it may not be possible to get an approximate axial length. If you are using the ultrasound biometer to obtain the axial length in this patient, the difficulties that you see is that the presence of silicone oil in the posterior segment slows down the speed of the ultrasound. There are multiple retinal echoes. The retinal echoes are very, very small. And the axial length that you obtained is an apparent axial length, which has to be subsequently converted to the true axial length before going in to measure the IOL power. If you are using the velocity of sound in the normal vitreous, which is 1532, your vitreous gate in your ultrasound machine is set at 1532, then you have an apparent lengthening of the globe. This can be avoided by using an optical biometer. You just have to change the setting to the axial length setting to the silicone oil filled eye mode. In this situation, to find out the true axial length, you can either use a conversion factor which is available, or you can use the formula-based calculation. If you have a more advanced ultrasound biometric machine in which you can adjust the vitreous gate for the viscosity of the silicone oil that is there in the back of the eye. For example, if you are using, if the patient has a 5000 centistokes silicone oil, you can set the vitreous gate to 1040, or if you are using 1000 centistokes silicone oil, it can be set to 980 meters per second. If your patient has an incomplete silicone oil fill, you have the option of either getting the axial length from a CT or an MRI image of the orbit, or you measure the axial length of the patient sitting up. If the patient is lying down, your sound waves have to pass through the silicone oil filled vitreous, followed by a space, space which is filled with posteriorly circulated aqueous. At that interface, there may be disturbance, and then it travels to the pooled aqueous in front of the posterior pole before you get an axial length reading. To avoid that, in this situation, you make the patient sit up so that most part of the posterior segment is covered by the silicone oil bubble. In situations where you have not obtained an axial length with any of the above mentioned methods, you have the option of doing calculating the IOL power based on the axial length of the fellow eye, which is not a very wise thing to do. Intraoperative biometry or intraoperative retinoscopy are two other procedures which you can do in these patients and calculate the axial length and it has yielded very good postoperative results. In patients who have a significant macular edema, if you are using the ultrasound biometer to measure the axial length, you are measuring up to the surface of the internal limiting membrane when there is a thickened retina and the distance on the cornea to the RPE is altered. In this situation, you can add the central retinal thickness or the subfoveal thickness to your measured axial length. It is much simpler to use the optical biometer as the axial length is measured up to the retinal pigment epithelium. There are several studies to show this. And in these situations, when you're doing a phaco-vitrectomy for epiretinal membrane or for a recalcitrant cystoid macular edema, compensation for this underestimation of the axial length can lead to a postoperative refractory outcome closer to metropia if you correct by adding a small amount of the macular thickness that is measured on OCT to the ultrasound axial length, or you implant an IOL which is about 0.50 diopter, less than the IOL power which is targeted for emmetropia. So what about gas tamponade? When you have an expanding gas bubble in the back of the eye, it pushes up the lens iris diaphragm, and even after the gas is resorbed, the lens iris diaphragm does not come back to its original position, and you always have a shallower anterior chamber. This could be responsible for a small myopic shift in your refraction, and in this situation also, a target postoperative refraction of plus 0.5 addition of 0.5 is suggested to minimize the postoperative refractive surprises. In scleral buckled eyes, the axial length increases by about 1 millimeter. The depth of the anterior chamber does not change. It is just the back of the eye which elongates. And here also, a slight myopic shift in refraction is expected, and you adjust the IOL power down. If it is greater than 14 diopters, reduce the IOL power by about 0.50 diopter. And when to plan surgery in a buccal eye, you wait at least for a period of 3 months for the lengthening of the globe to stabilize before you post your patient for surgery. So what about silicone oil filled eyes? If you see, the refractive index of silicone oil is closer to that of the refractive index of the intraocular lens. So the silicone oil acts like a small minus lens in the vitreous cavity, and depending upon the type of IOL that you use, whether it is a biconvex, planoconvex, or the meniscus lens, the power postoperative refraction will also vary. So if you are planning to maintain the silicone oil for a long period of time, or your patient has a compromised posterior segment, and in which situation you cannot remove the silicone oil, you add about thumb rule is to add about 3 to 8 diopters to the IOL power that is calculated to achieve emmetropia, or you can use a formula-based calculation to find out the additional IOL power. But please bear in mind that subsequently, if the patient has a silicone oil removal, he will have about 3 to 5 diopters of myopia, and you should inform this to your patient beforehand itself. The accuracy of newer generation IOL formulas, they are very good predictive accuracy, and using the Van Cox axial length adjustment in eyes with an axial length greater than 26 millimeter, the predictability is very, very good. Thus, to conclude, we are leading with patients who have compromised posterior segments. They are very delicate eyes, and we should do whatever is possible in our hands to optimize their visual recovery after a cataract surgery. I thank you very much for your patient hearing.
Thank you, ma'am, for lucidly covering the various aspects of IOL power calculation in vitreoretinal conditions. Our next speaker is Dr. Suven Bhattacharjee, who will be talking on post-refractive surgery IOL power calculation.
Thank you, Dr. Nirupama, and thank you, Dr. Arup, for inviting me to this course. Most, if not all, or rather at least I was one of those who were actually pretty okay at mathematics and physics in school, but joined medicine thinking that we've probably done enough of mathematics and physics, and we see we're back from the frying pan to the fire. So I'll try to keep this simplified, and I acknowledge the contribution of Dr. Sagar Bhargav for educating me on some aspects of this. So a quick revision of biometry errors. Axial length, if you go off by 1 millimeter, you have a 3 diopter post-op refractive error. Keratometry, if you go off by 1 millimeter, it's a 1 diopter equivalent. And anterior chamber depth, if you're off by 1 millimeter, it's a 1.5 diopter error. Now, the problem with refractive surgery is standard keratometry methods do not apply, and standard formulae both also do not apply. Simply because the parameters have been changed. If you check at the standard formulae, the corneal power is somehow directly, it's calculated from the postoperative refraction. The corneal power is also used in prediction of the ELP. That's relevant over here. So like in any computerized system, if you put in rubbish, you're going to get rubbish. So if the data that we're going to input is not going to be of value, you don't get useful information. So post-refractive surgery, as you know, is laser vision correction, which would be all those procedures for myopia and hypermetropia and RK. Now, the problem with keratometry in laser vision correction is they modify only the anterior surface. So the normal anterior posterior curvature is altered. In standard keratometry, it measures only the anterior corneal curvature. The posterior curvature is actually derived or extrapolated from that. So, and this extrapolation is no longer valid after a laser correction. In radial keratotomy, what happens is anterior-posterior relationship may be maintained, but the optical zone becomes smaller, and there is a central flattening due to the corneal edema also in the post-op phase. And there is something called a radius zone error. See, what we were measuring, standard automated keratometry would measure at about 3.2 or 3 millimeters, but we in myopic elastic or PRK, we have increased the optical zone to much larger place. So, and in hyperopic elastic and RK, we have reduced that optical zone. So those parameters, we're not actually measuring the corneal power that we want to measure. So if you look at post-RK, corneal changes, if you look at this, what has happened is the central cornea is flattened, but it's a smaller area than the area that would automated keratometry would measure. In post-elastic or PIK myopia, the changes are very different. It's a larger area which is flattened, so which is off again from what we'll be measuring. So depends upon the ablation zone. In hypermetropia, it's again very much like your this thing RK, and here again the anterior curvature, the ratio is altered. So the effective lens position, although IOL calculation formula differ in the methods in estimating, in some point they use this process, the measurements that we use. So in myopic ablation, there will be reduced corneal power, and it's anteriorly incorrectly assumed to be in an anterior position. So there will be an underestimation of IOL power, and there will be a hyperopic shift. So, yeah. So the remedy would be in post laser vision keratometers to measure both anterior and posterior curvatures. So any device which gives you that will give you a more accurate reading of the corneal curvature, and your formula may be effective. In post RKIs, take into account whatever is the small optical zone that we have created, that needs to be accounted for. So these are the various ways. I will not go too much into detail. So it's the corneal topography. There is a SIM-K method, and then the Scheimpflug photography, and the OCT method, which is now actually more prevalent and is being used more and more to predict, to measure the posterior corneal curvature. So this is IOL 700, which uses a total keratometry. That's something called telecentric keratometry, which measures different points. And a OCT is used to directly measure the posterior corneal surface and get a accurate corneal pachymetry as well. So that's proprietary over there. So in regular eyes, it doesn't really matter. Manual keratometry, autokeratometry, K from optical biometers are all equivalent. But unusual eyes like post-classic or PRK and keratoconus is a ratio between anterior posterior corneal curvature that's lost, and that's where. So in that order of preference, IOL 700 Anterion and OCT-based Scheimpflug devices work. I mean, the accuracy works that way. Post-RK, where the corneal thickness is not altered, but the central K is different from the flatter paracentral K, there are other topo, Zeiss topo, and OCT-based similar devices work, but again, we have to account for the smaller optical zone. So, post-refractive formulae overcome standard formula issues either by correcting the formulae or by the results for the issues that we have talked about already. So again, I think all of my colleagues over here have spoken of all the formulas, so we won't go into that. Now, to make all life much easier, we've got very generous, nerdy people who, like Dr. Graham Barrett and Van Kock and a lot of other people, Warren Hill, Lee Wang, Douglas Koch. So these people, they have already put it up free of cost on ASCRS and APSCRS websites. All you need to do is put in the data properly from whatever devices you have, and it gives you a huge range of devices that you can use, and to the extent that you can give. So the more data that you put in, the better results that you get. So you should aim, and it calculates across various formulae, and you can go to a median range and choose your lenses. So that's about all. I would recommend a good history and counseling. We must keep the patient's expectations very grounded, because we know nothing is infallible. And there are plenty of situations where, despite all calculations, we have failed miserably. Rest is as we discussed. Thank you very much for your attention.
End of the instruction code. Yeah, I'll be summing it all up and delivering a few take-home pearls. So the main aim of achieving a bang-on target post-op refraction, the holy grail 6x6, is first and foremost is to tackle the ocular surface. So approximately 60% of cataract surgery patients have dry eye. So it is important to first treat them of the meibomian gland dysfunction, and if they are wearing contact lenses, make sure that we discontinue and then measure the keratometry or the optical biometry, and it should always be on a virgin cornea before using any eye drops or any other contact procedures. And as Dr. Arup had mentioned, even before dilating the patient, it is good to go ahead with the biometry. And always repeat the measurements if possible with 2 instruments, if not at least on 2 sittings. And the 2 consecutive readings, if you get a concordance, it is better to use those values. And always repeat measurements with more than one formula, so that you know that you are bang on the target IOL power calculation. Always interpret the values with caution. Compare both the eyes for any asymmetry. If the axial length is more than 0.3 millimeter, keratometry or the IOL power is more than 1 diopter between the two eyes, it's better to recheck whether the calculation has been done correctly or not. And always take the patient considerations into the calculation, whether they need emmetropia for distance, intermediate or the near, and follow up your cases and see the refractive outcomes. That helps in optimizing the A constant, which predicts the power prediction curve and helps us to calculate IOL power over a wide range of axial lengths. So there are so many tools which are available, which Dr. Ramesh has very nicely told us. But the most popular and the favorite one is the Swept Source OCT based devices, and the Zeiss IOL Master 700 comes first. So of all the new technologies that are present, the advanced formulae are the boon which have come in IOL power calculation, because most of the formula, they work well in the normal range of IOL powers, which is between 17 and 25 diopters. But for lower powers and higher powers, that is where the errors come into the picture. So the advanced formulae are now available, which help us to calculate the IOL powers more accurately, even in myopic eyes or hyperopic eyes. So we also have preoperative aberrometry assessment and also intraoperative aberrometry, which actually adds on to our armamentarium and helps in achieving target emmetropia. And also the availability of newer IOLs, which can be customized, even customized toric and even high and low power IOLs are available, which help us in giving the best refractive outcome to the patient. For toric IOLs, for beginners, it is better to choose stable, consistent and regular astigmatism. And there should be an agreement between the spectacle refraction, the optical biometry, the topography and the eye trace value of the keratometry. The axis power, the axis should be less than 10 degree and the power should be less than 0.5 diopter variation when we measure with these various devices. And the online toric calculators, multiple are available, but the baric toric calculator is the best because it allows us to feed either the predicted posterior corneal astigmatism or the calculated posterior corneal astigmatism from other devices into this online calculator, which finally generates the IOL power. So the posterior corneal astigmatism has to be taken into account when measuring the keratometry for toric IOL cases, because with the rule astigmatism will be overestimated and against the rule astigmatism will be underestimated if the PCA is not taken into consideration. And always remember that the toricity at the IOL plane will be higher than the toricity on the corneal plane, and this will vary with different factors. And we should also consider the patient's age, the type of astigmatism, the surgically induced astigmatism, the site of the incision, and also the depth of the IOL plane for toric IOL power calculations. And previously the SIA used to be calculated, but now it is actually a mean centroid value, and it is approximately 0.08 to 0.14 when the surgery is performed using temporal clear corneal incisions. And for toric IOLs, we must make sure that there is complete OVD removal at the end of the surgery. Otherwise, the chance of re-rotations is a possibility. And once there is a rotation, if we have to correct it, the best to go is astigmatismfix.com, the online website, or even in the Barrett suite, we have the Barrett RX formula, which will actually tell us what degree the re-rotation has to be done. For post-refractive surgery eyes, always remember for post-RK, there is alteration in the corneal curvature and also the optic zone which is measured. And there is a long-term hyperopic refractive drift. But the Goulstan ratio between the anterior and posterior corneal curvature is maintained. But in the post-laser vision correction, that is the LASIK, PRK, SMILE or LASIK, the curvature is altered, the optic zone is altered, and also the ratio between the anterior and posterior cornea is also altered. So the best formula which many cataract surgeons would agree upon for post-refractive surgery eyes is the Barrett True-K Universal 2. And the same thing applies to also irregular corneas with keratoconus, pellucid marginal degeneration, post-LASIK ectasia or decentered ablation. And the True-K helps because it measures not only the anterior and posterior corneal curvature, along with that even the corneal thickness, and gives us the true measurement of the keratometry. And it's possible to calculate this using the newer devices like the IOL Master 700 Anterion, or if we have a topography based Scheimpflug device like the Oculus Pentacam, we also get the Holiday EKR, that is the equivalent K reading report, which also is a very accurate keratometry for using in the post-refractive surgery eyes. For post-myopic LASIK, you can target a minus 0.5 diopter residual, and post-RK, better to aim for a more higher target of -1. In situations like high myopia, where the axial length is more than 25 millimeter, the posterior staphyloma is the one which makes the foveal estimation difficult, and there is always a paraxial overestimation of the axial length. So if we are using the older formulae or the Virgin's formulae, we have to do the Bangkok modification like SRKT or Holiday 1 or Haggis. But the newer formulae like Barrett Universal 2, Olsen, Hill RBF, Kane or EVO can be applied directly, and they are giving a very accurate IOL power calculation. For shorter eyes, less than 22 millimeter, the main problem is the getting the correct estimation of the ELP. And because these are higher powered IOLs, the smaller errors get magnified. And the advantages, we have higher powered customized IOLs available now. And for VR surgery cases, there is always an overestimation and eyes filled with silicone oil. And optical biometry is ideal, or it is also better to schedule biometry after removing the silicone oil. And aim for a target refraction of plus 0.5 in gas-filled eyes. And remember that scleral buckling causes globe lengthening by 1 millimeter and can result in a myopic surprise. So with this, we come to an end of this instruction course. I thank you all for a very patient listening. If there are any questions for the speakers, we can
Yeah.
go ahead.
So thanks a lot, Dr. Nirupama. We are still awaiting Dr. Kumar because he is in the IPL and he told me he'll be coming anytime. So I had to unfortunately go for another course at the same time. So Ramesh, any questions from the audience? Because we have with us Dr. Ramesh, who is an authority on IOL power calculation, and many of us who have taken a lot of abiding interest in IOL power calculation. So we'll be very happy to share with you our thought process on IOL power calculations in various situations. So if anybody wants to ask any question or would like to contribute, we'll be very happy to take your inputs. Yeah. Mike,
So we get surprises.
come again. No. The mic is working. Use the mic.
Yeah, routine cataract surgery, in spite of good IOL power calculation, using a IOL master, sometimes we get refractive surprises. So what steps intraoperatively we have to be careful so that the effective lens position is as expected. Sometimes we see a lot of gap between the IOL and the posterior capsule. So that leading to high myopic shift to as much as minus 2.5 to the patient, and we have to go make a small opening in the PC and it will fall back. So what intraoperative steps we have to take care, or where we are going wrong?
Ramesh, would you like to take that?
So you obviously had a patient who had a capsular block syndrome, and so he
Yes,
had some kind of
something like
fluid
that.
behind the optic,
Yes, yes.
shifting the optic forward, making him temporarily
Yes.
myopic. So you had to
Yes.
YAG for the posterior capsule.
Yes, sir. Yes.
So to avoid this, what I do is in at least 2 or 3 clock hours, I will remove all the capsular cells and I will polish it.
Anterior capsule, subsurface.
Yes. So I'll make sure that I have some kind of a pathway there.
Okay. So that,
In spite of this, if you have a capsular block, it is safe to do a capsulotomy of the posterior capsule.
okay, anything to do with the size of the capsule or anything? Why most of the time some lenses are coming forward?
So if you, not nowadays, but though in earlier years, we used to have a lot of 3-piece lenses.
Okay.
Even now, we have many lens models where the haptic is angulated forward.
Okay.
So the theory was, if it is angulated forward, the optic is pressing on the posterior capsule and it prevents PCO. That's the theory behind these lenses.
Yes.
But in effect, what happens is, in the post-op period, the capsule shrink wraps and contracts. So the anteriorly angulated haptics become flat, and as it flattens, the optic moves forward. So you can expect a little bit of myopic shift in any lens which doesn't have a flat configuration. So if you compare the Technis and the Alcon lenses, the Technis has got slightly anteriorly offset haptics. You will have a little bit of shift when compared to the Alcon. You have to take care of this in your biometry.
Okay.
The single most important thing, not to have a wide spread of post-op results, is to have a 360-degree overlap. So when I was in the habit of making very large rexes, because I used to operate on 660 and 636 and 6 very dense cataracts. So large rexes made it easier for me 20 years ago. But my refraction was not very, very tight. It was a big amount of variation was there. Once I made the rexes smaller, you tend to get much better results.
Smaller in the sense 5 or 4?
Anything smaller than the optic should do well.
Okay. Thank you.
So normally we would target anything between 4.5 to 5.5, all right, not
Not
beyond
smaller
this range.
than that.
Now, addressing your refractive surprise, I mean, could you just tell us, out of, let's say, 10 cases with optical biometry, what sort of cases? You said it's routine case, a normal
One
exam
particular
length,
IOL, which in our center we'll be using at least 50 per month. We are getting at least 4 to 5 surprises with that particular lens.
I think that is quite a high number. 4 to 5 is quite a high number.
Yes. And many a times this is the problem. It is anterior shift and it is giving high myopia.
So if I get a refractive surprise, like that, suddenly it has happened, I would review the case sheet and I'll find out the optometrist who has done the test.
Yes.
And I'll again go through the whole process, what I have described.
Yes.
When was the biometry done? Was it done on the same day? I will question the values.
Yes.
Whether keratometry was proper or, was it reliable or not?
Yes.
And things like that. So that is one thing. Second thing, I would again find out what exactly was the lens. If it is a lens that I've been very familiar with, so usually this kind of vaulting, as Ramesh was mentioned, it is not seen. Anything, it may happen. But then what I've noticed is there is a batch-to-batch variation in some of the lenses which come out from the domestic market.
Okay.
So with that, somehow you have to take a call because you have to be answerable to each and every one of your patient when things go wrong.
Yes.
And then another thing is, of course, it is surgical induced astigmatism is not much. Incision 2.4 millimeter. There's OVD to be removed as much as possible, as Ramesh has mentioned. So sometimes, in spite of all that, you can have a refractive. You can go away from the target refraction by whatever you targeted. So in that case, you can take inputs from the fellow eye, the operated eye, when you operate on the second eye. Like if there is intraocular symmetry, both eyes are symmetrical.
Yes.
And you got a surprise after eliminating every cause. It was not a wrong IOL part that was included, not wrong transcription, because we are manually entering in the website.
Yes.
So nothing wrong was done. And it was more than 0.5 millimeter, 0.5 diopter. So I would adjust, most of them is a Barrett Universal 2. So I'll adjust the target refraction depending upon about 30% for Barrett Universal 2. On the opposite side of the target of the refractive error that I have got, not the full. Like if I've got a 1 diopter surprise, I'm not going to reset the target refraction by 1 diopter, only 30% of that. So I think it happens because you do not know how the capsular bag is contracting, Ramesh. The effective lens position, we know in a given patient what happens, but with a particular lens, but in a given patient, how the bag is contracting and everything is different. So this but it should not be a very big surprise.
We are using Barrett Universal 2 formulae, and I'm using 2 machines. I'm using OA 2000 and Sonomed B-Scan. So I do it 2 times. And we have repeatedly reviewed the cases. So many a time this particular lens it comes forward from the PC. I take a lot of effort to push it back with the Sinski. I wash below the IOL, and then but that keeps repeating. So I
Then
don't
you
know
may
where
have to
I'm
review
going
the
wrong.
way the lens has been placed and pushed inside. It might have been flipped, or they might not
No
have
flipping, sir. No flip. No
Or
flip.
the
loaded
lens
the lens
memory also, no,
properly.
supposing the lens has been damaged, and then it has lost its memory.
Yeah,
It
please.
stays damaged.
This
Yes.
particular same problem, some lenses do have, that while you form the anterior chamber, the optic of the lens just comes up. You can just see it actually. So when you're forming the anterior chamber, some lenses have that. So one thing is that there's nothing much we can, either we don't use that lens, or we have to keep a watch on that and tap it down and don't pressurize the AC too much. And at the end of it, we use, you may also be using antibiotics, moxifloxacin. So that moxi, we irrigate into the bag and the anterior surface of the IOL. So when you irrigate it into the bag on the anterior surface, the IOL gets pushed behind. And most of the time, it flips only when you're forming the AC. After that, it doesn't happen then.
Yeah. Any other question?
In RK patients, sir said to take the central area keratometry from the central area.
Can you come closer to the mic?
In RK patient, sir said to take the keratometry from the central area, but central cornea, but we take from 3 to 4 millimeter. The machine calculates 3 to 4 millimeter.
What is it?
Keratometry.
So you're right. So she said no. With an RK patient, we had to take if possible, a 2 millimeter measurement. But most machines are fixed at about 3 to 3.5 mm.
So what would you advise?
So the solution is we had to take the K from a topographer or from a tomographer. So if you have an RT view, for example, or any swept source instrument or any tomographer with scans across the cornea, it will give you the thickness and the power map of the center of the cornea also. So we can't depend on our manual K in a patient with RK. So if you use an Atlas topographer, they have a 2.0 millimeter small square. So that's what's used in the US. But in India, we don't have many people having a size Atlas topographer. So for us, the easiest option is to take the power from any machine which gives you a corneal power, from a tomographer. Use a tomographic value.
I think iTrace would take care of that problem, isn't
Yes,
it?
Yes. Yes.
So that is the reason, some of us, we get all our parameters from the biometric parameters using an optical biometer. And then we also supplement it with iTrace and with a topography. So to get additional, it is not really necessary for all patients, only in cases like that you mentioned, it becomes really useful. Otherwise, routinely it is not necessary, but sometimes you pick up some surprising elements from these additional tests, particularly for multifocal lenses, for toric IOLs.
You can also take the central K from a Cirrus or an OptoView. So they all can be used.
Biometry suggests a toric IOL.
Sorry?
But biometry has suggested a toric IOL for a particular patient. But the patient is not willing for that package. And now we have decided to go with a spherical lens. Now, what should be our target refraction with the spherical?
So there are two ways of looking at this problem. So if you have a 2-cylinder and you are targeting plano, you are going to get a plus minus refraction after surgery. So your question is that, isn't it? So most people feel you must target a little bit of myopia. So if you have a 2-cylinder, target a minus 0.5, so that
What I'm doing is, I'm taking half of that cylinder. Suppose 2 diopter astigmatism, half of that is 1 diopter, and I'm targeting -1 postoperative refraction. Is that okay?
Beautiful, that is okay. I used to do that, Sudarshan. But then I found some of my patients are not happy because the near vision is extremely good, but distant vision is not good. So I started to target half of the distance, 1/4. So the part of the Strum's conoid that is in front of the focal point, half that amount. I used to take the full amount. So for a 2-cylinder, instead of targeting -1, I nowadays target 0.5.
No, but then, Sudarshan, before the toric IOLs came, before the toric calculators came, I mean, we are managing these patients, isn't it? With cylinder, we're using the standard calculators. So why would you like to change? I mean, say basically Barrett Universal 2 also it uses Barrett toric calculator uses Barrett Universal 2 to calculate the, the toric IOL. So if you just go back to the Barrett Universal 2, it will calculate the spherical IOL also for that patient, isn't it?
If we targeting emmetropia, like what Dr. Ramesh said, we are getting a plus and a minus. It's like a cross-cylinder prescription post-operative.
Sudarshan, actually, I find that the Indian toric lenses are very good. So even if they can't afford, I feel it's better to put a toric lens for these patients. So a person with 2 cylinders and above, I put Indian toric.
Yeah, we do that also when the astigmatism is very high.
Yeah.
But these are the borderline cases.
If possible, Sudarshan, get a diamond blade and do LRI for these patients. It'll work. Post-op also.
Yeah. Please use the mic.
Sir, nowadays glaucoma person increasing in scenario. So chamber depth जो है sir very low, and anterior chamber depth and lens thickness both are variable. How to decide I will go to power increase or decrease? How to decide?
I didn't understand your question, sir.
I think
nowadays, glaucoma persons, glaucoma patients are increases, or angle closure glaucoma, other phacomorphic, other. In this case, the chamber depth are very small, 1-2 millimeter, and lens thickness is more. How to decide? Lens power is increased or decreased?
Not really a problem, sir, because all the multivariate formulas ask you for the lens thickness, and even with the regular, yes, sir. So it's included in the formula itself. It will take care of that.
नहीं सब फार्मूला तो सर दिया रहता है सर, बट सर इन केस ऑफ ग्लूकोमास के लेंस थिकनेस या चैम्बर जो है सैलो होता है, उसके कारण जो है वी कांट डिसाइड जो है हाउ मच पावर इन पोस्ट ऑफ जो है refractive surprise are taken.
So, no, sir, I think it is a very interesting question. Your question is, when we have patients with a very thick lens or a very shallow anterior chamber, do we have to manually adjust the IOL power? So what Dr. Ramesh has been trying to tell you, and we also agree to that, is the newer switch over to the newer formulas. But the older 2 variable formulas, 3 variable formulas, maximal, and they took into account the anterior chamber depth. Today, the Hill RBF, the Barrett, and many other Kane formula, all these take into account the lens thickness. They take into account the corneal, wide to wide diameter, corneal thickness, anterior chamber depth. So, and then they calculate the effective lens position and give you the intraocular lens power. So basically, it is not only a question of using a better biometric device. It is also a question of using a new generation formula. As I mentioned, last 5-10 years, 25 new formulas have come up. And
which formula?
25 new formulas have come up. I'll be talking about it in a talk tomorrow, the newer advances in biometry. So that is in the National Symposium. So a lot of formulas have come up. So it is basically the newer formulas which have been a game changer. They are giving us much better outcomes, isn't it, Ramesh, compared to the older formulas that we're using. So you're getting better quality data. You're utilizing the data in a much more effective manner, much more precise manner, and you're getting an IOL power according to those formulas. So you don't have to say that, okay, because set up a target refraction of 0, plano, and or maybe whatever it is. Normally, we take the first minus power, and then that is the lens which gives the first minus power. That is the lens that we normally choose. So I'll not deviate from that particular philosophy.
Sir, I'll make one small change, sir. In intumescent lenses where it's really thick, I generally choose the first plus because I find my post-ops have a little bit of minus in them. So intumescent lenses, whatever the formula I use, I will choose the first plus.
You mean to say the very thick cataracts?
Yeah, for very thick cataract. But in general, for all phacotraps, I'm putting the lens power which is chosen by the formula, sir. So you can use your Barrett, which is free, sir. It's online and free.
Okay.
And length thickness value we can get from the ultrasound as well as the optical biometer.
So you basically get better, more measurements, more accurate measurements, use proper, more advanced formulas. This question will be, will be answered. You will have no surprises.
And I think we should tell our patients with the best of technology and with the best of lenses, best of surgeons, all over the world, everybody only gets 90% within 0.5 diopter. That means that if you do 100, 10 of them will be having more than 0.5 error. That is normal. So you cannot tell every patient, oh yeah, you'll be fine. You'll see clearly. The world's best surgeons are only getting 90%.
But our last speaker has come. Excuse me. Dr. Kumar is here.
So one more speaker. So somebody will get a 0.75 and 1 in 200 will get a 1. That is the way the formulas are.
Okay, sir. Thank you, sir.
Yes, sir.
Sir, small doubt, sir. Sir, is it better to do IOL power before formological dilatation or is it better to check IOL power?
Yeah, see, the thing is, I think I had briefly addressed that aspect. Any dilating drop that you put on the cornea, it's after all a insult to the cornea, pharmacological insult to the cornea. It's no longer a virgin or a naive cornea. So there will be definitely SPKs and maybe some inaccuracies in the measurements will creep in. That's number one. Number two is what we have been here learning from the recent literature, and this field it's a very active field. Every now and then some new concept comes in with good evidence, good solid evidence. So it shows that if you dilate the pupil to get ultrasonic biometry more accurate, you're not getting it after dilatation. You got it. It changes the some of the parameters. All right. And if you use those parameters in the formulas, you end up calculating an IOL power which is 0.5 to 1 diopter more than what would have been the actual power, which means the patient will be landing up with a negative power overcorrected. All right. So this aspect is, I tell all my patients that we have dilated to get precise results. So because we are not getting a result, we are dilated to get a result. And this, in 25% of the patients, we may not hit the target refraction. We may deviate by 0.25, 0.5 diopter. So we tell the patients beforehand. Another recent study that I just mentioned, the Swepsor OCT-based study, so that showed that if your scan qualities are not good in advanced cataracts, in routine undilated situations, that is what is desirable normally, routine undilated situation. You dilate, many of them you get very good scans, and then you are getting a reliable scan. But then other study also is relevant. That because whenever you put a dilating drop, the biometric parameters are changed, and that is going to affect the IOL calculation by the various formulas. So I think we need to have a good discussion with the patient and say that this is where the science is at present right now, and there are certain things we don't know, things why they happen, but we will do the best for you. But we need to be aware what is the correct latest evidence in the literature. Yes, Kumar.
Good afternoon, and thank you very much for this opportunity. I'm going to talk about, can I have my slides? Yeah. IOL power calculations in very short and long eyes. With today's era, this is the data that we had. So this is modern cataract surgery. They all want perfection. We also want perfections. Patients' expectations have increased, and doctors' expectation and delivery to be giving good results has also improved over the number of years. So there was an old study done by Warren Hill where he said that about 78% of the ophthalmologists can get a target of 0.5, 6% of surgeons got 84% and better, and 1% of surgeons got 92% or better with the older formulas that were being used. So 95% of your patients are very good in the axial length of 22 to 24.5, but beyond this and ahead of that, so before and ahead, 2.5%, 2.5%, which are the outliers where the results were a big question mark. So it is said a crime is just like a jigsaw puzzle. To solve it, you need to have a jig and, of course, have a saw, right? So this we need to have both. So we need a combination of accurate biometry and an accurate formula, without saying that, of course, you need to have a perfect surgery. So accurate biometry itself has come a long way over the number of years that it has improved. We have ultrasonic biometry, we have optical biometry, and interop-aberrometry. Ultrasonic biometry, I personally am of the opinion it should only be immersion. You do not do contact biometry at all. And there's no also doubt that optical biometry is better than ultrasonic biometry. The error caused by 1 millimeter of compression by mistake, it can give an average error of 2.5. In long eyes, if you give an error of 1.75, and in short eyes, it will give an error of 3.75. So this is an error that can happen. A good scan, we all know this, in immersion, you can have a good scan, but a bad scan, you'll have wrong echoes at the wrong place, and that's not going to give a good result. As far as optical biometry, you have a huge list of instruments that are available. We have IOL Master 500, 700, Lensstar, Aladdin from Topcon, Galileo 6 from Zimmer. We have iStar 900, and now I'm using the Anterion. I also have a Lensstar, but Anterion personally I feel is phenomenal, because it's an anterior segment OCT as well as optical biometry, topographer, aberrometer, all included in one. So this gives a big advantage in comparing different results that are there. I just want to show the first slide. Where does the error actually come from? So this is what has been also documented, that corneal keratometry results in 27% of the errors that are coming out of results. IOL misalignment is 14.5, IOL tilt is 11.3, and angle kappa is 7.5. So this is where the errors are coming from. Of course, we know that IOL tilt can only be measured on eye trace, and no other machine can actually measure an IOL tilt. Now coming to swept source OCT, this is much better because it measures keratometry more accurately. Axial length, central corneal thickness, anterior chamber depth. Lens thickness is very, very important because it can tell you predicted lens placement, one, and two, EPL can be much better out of this. It will also give you a white to white and much more higher accuracy. Foveal fixation is there or not, you'll come to know if there's a posterior staphyloma and poor fixation. There are also now new biometers actually give you a spot, and you can increase the intensity of the spot. You can also put in refractive error so that all these defects which are happening in the older optical biometers are not there in the newer optical biometers. Measurements possible in eyes with dense cataracts, which was not possible before, so media opacities, and big advantages that it measures the anterior and posterior corneal curvature at the same time and gives you total keratometry, which is more relevant in calculation. So now the question comes to which IOL formula to really use when. Over the number of years, we had the SRK-T, SRK-1 and 1-2, and then all the other formulas which were originally being used. But you can see here that Holiday 1, half a Q, all depends on the axial length. And reasonably good studies have been conducted where there is now the new induction formulas is ray tracing. So there is an Olsen and Oculix, which is there in some of the biometers, which helps you to do this. We also have the Hill RBF, where you feed in all the data, it gives you data back. So it's like artificial intelligence, and this gives a big advantage over the older formulas which were there. Conventional teaching says that average eyes of 22 to 24.5 Holiday 1, short eyes you use half a Q, medium to long eyes is better to use Holiday 1, and extreme long eyes one can use SRK-T. But over the number of years, this has again changed because we know that now small eyes have shallow anterior chambers, long eyes have deeper anterior chamber, and it's true that these percentage of cases where the most of the errors really happen. How does anterior segment size actually vary? And this will result in a wrong EPL calculation, and that's the reason why these errors happen. So you can see that if you have a large megalocornea, large axial length, the megalocornea and large bulbophthalmos, all of this will result in a different axial length measurement, and you will get an error in that level. So optical biometers do tend to measure axial length higher than what it actually is in an axial length of more than 24.5. Hence, in more accurate results, then came the Waring catch axial length modification, which got further improved, and this got incorporated, and this gave much more better results. And that actually helped in getting much more accurate results in smaller, shorter eyes. Small errors in the measurement of much greater impact on short eyes, and that's the reason why the lens, much more powerful eye has to be used. Short eyes susceptible to small variations in effective lens position. Typical errors in such eyes are unexpectedly in myopia outcomes, as the IOL ends up sitting little more anteriorly. So if you have a smaller hyperopic eye, a high hyperopia, the lens may sit more anteriorly, and that may result in error. Over the number of years, all the formulas have worked out, but just to conclude that a Barrett Universal 2 has given the best results till now. With the application of the Warren-Koch axial length modification, will help you in hyperopic and myopic outcomes in long eyes. Barrett also said that the least prediction, so you can see that Barrett and Olsen are doing the best for long eyes. This also is proven. And another thing is, if you have a long eye, then Haigis also does very well. And if you have a post-op refractive eye, then the Haigis L also does very well. This is just over the number of years, the things have improved. But you can see that Barrett 2 is covering reasonably everything that you nearly need in today's work. To summarize, it's an extremely long or short eye in modern formula. The Barrett Universal 2, Hill RBF, Olsen and Holiday 2 work very, very well. Additionally, some studies have shown that the Haigis is more optimized with an axial length of less than 22 and ACD more. And one more thing is that if the eyes are with axial length more than 25 mm, Holiday 1 also works well with the adjustment from the Warren-Koch that has to be applied to that. Steps to optimize outcomes with extremely long and short eyes. This is your lens constant. Validate your measurements. Do not move from the process. And keep checking and keep making sure that you see the post-ops yourself to really know what is the outcome of the result. I'll show a small video. I'll just show one part of the video. This was, I think, first time we ever implanted. Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in two cases, extremely short axial length and a small ACD, namely the nanophthalmos and microphthalmos with an iris coloboma. A unique complex case, a software engineer by profession with high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea and a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG PI in both eyes. Her dilated fundus examination revealed heaped up optic nerve head and... So what I'm trying to say here is we went ahead and did a clear lens extraction for this girl. But if you see... CD of 2.68 and her lens thickness of 4.27. So we have a white to white of 10.7, ACD of 2.68 and a lens thickness is 1/4 the actual size of the whole eye. So we know that we are dealing with a nan-ophthalmic eye with a IOL master of 14.85, an AL scan, which I had a NIDEC AL scan that time, 14.83, and a keratometry of 54 and 57. You try to put this data in many formulas, it will just tell you out of normal reach, and won't let you calculate. We still went ahead and did calculations. Hoffer Q said 65 and Holiday said 48.5. So the question was what to really implant. I decided to put a 65 diopter. This was a choroidal scleral thickening of 2.3. So it was an extremely small eye, like a nan-ophthalmic eye. We didn't know really what to do, but then we got a lens manufactured personally, and we decided to do a clear lens extraction for this patient. And there are challenges which all the precautions are taken because you're dealing with an eye. I did not make any nick on the sclera, which some doctors do, but with all the modern things, like putting the rest of it, I went ahead and did femto. The reason I did femto was my rexis would be ready. That was one big advantage here. Rexis and a 4-quadrant division of lens performed. A 0.75 millimeter side port incision made and a gentle release of the aqueous, replaced by an OVD. Using a microrexis forceps, the CCC was rasped out. I didn't do hydro. Bimanual IA. Straight did bimanual IA. The lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 millimeter made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge and then injected. Loaded the hydrophilic IOL. Significant amount of pressure needed to push the 1.9 millimeter thick IOL through a 3.4 millimeter cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag, and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed. Post-operatively, overwhelmed to see the first day post-operative visual acuity of 20 by 60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20. So this was the smallest eye I've ever operated, and I got a brilliant result. So of course, God was with me at many steps of surgery and the calculation. But this is what I've attempted and reasonably succeeded quite well. Thank you for your attention.
Thank you, Kumar. It was a wonderful presentation, very nice video. And we are already beyond time by 5 minutes. Maybe we'll just take up one question if anybody has, or any comment from anybody before we wrap up the session. Okay. Thank you, Kumar. So I think, we had a very engaging session, though we had to, there is a lot of audience involvement, and we really enjoyed, doing the session. And thank you very much for being here. Thanks a lot to the panelists, Ramesh, Dr. Nirupama, Dr. Meena, Kumar, and Shubhen, etc., for being here. And we hope we were able to give you take-home messages through Nirupama's presentation, and it will improve your, refractive results. And we'll be back with an update if it is accepted next year in Calcutta Conference 2024.